We can't see it. We can't feel it. But there is a silent killer between us. According to an estimation, 1/3 of the worldwide adult population suffers from hypertension. Out of these, 1/3 are unaware of their condition. Whereas 1/3 of the hypertensive patients fail to achieve the goal of keeping their BP under 140 by 90. In both developed and developing countries, it has been observed that hypertension happens to be the leading risk factor and cause of mortality. With every double-digit increase in systolic and diastolic blood pressure, the risk of CV mortality doubles. Here in this graph, we have results from a study which was conducted on 1 million adults, aged between 40 to 69 years, and blood pressure greater than 115 by 75. It was observed that with every 20 mm increase in systolic blood pressure, and 10 mm increase in diastolic blood pressure, the risk of CV mortality doubled. In the same study, it was also concluded that with every 2 mm decrease in systolic blood pressure, there is 7% reduction in risk of ischemic heart disease and other vascular disease mortality, and 10% reduction in risk of stroke mortality. Most patients with hypertension will require 2 or more antihypertensive medications to achieve their BP goals. Several guidelines acknowledge that most patients need combination therapy to achieve BP goals. ESH guidelines suggest that combination treatment should be considered as first choice when there is CV high risk. NICE guidelines advocate that many patients will require more than one drug to achieve adequate BP control. Similarly, JNC8 guidelines recommend use of combination therapy where systolic blood pressure is over 160 mm of mercury and diastolic blood pressure is over 100 mm of mercury. Over time, many trials have been conducted that advocate use of 2 or more antihypertensive drugs to achieve target systolic blood pressure. Within the spectrum of combination therapy for the management of hypertension, ARBs plus CCBs are considered reasonably effective. However, certain attributes of the Telmisartan+Amlodipine combination sets it apart from all other antihypertensive combinations. So, why Telmisartan out of all the sartans? Telmisartan is an excellent antihypertensive and has some distinct pharmacological properties which provide multiple benefits to the patients. Telmisartan has longest plasma half-life among all ARBs, which equals to 24 hours. This ensures prolonged BP control, especially during early morning hours, when BP surges and causes CV events such as stroke and myocardial infarction. This is why Telmisartan is the only ARB that is approved by FDA for protection against cardiovascular events. Telmisartan also has the highest trough-to-peak ratio among all ARBs, and it values up to 80%. This means that the patients get excellent control over BP, even at the final hours of the dosage. Some other benefits of Telmisartan include lowest level of excretion through renal route in ARBs, and values at less than 2%. Highest volume of distribution among all ARBs and equals 500 liters. Strongest binding affinity to AT1 receptors among all ARBs. Telmisartan is also ideal ARB for patients of metabolic syndrome. Telmisartan activates the PPAR gamma over 10 times more than other ARBs. PPAR gamma activation causes increased insulin sensitivity, reduced triglyceride levels. Sometimes PPAR gamma also increases HDL levels. Telmisartan is also beneficial in cases of diabetic nephropathy. As per findings of the detailed study, Telmisartan is equivalent to the ACE inhibitor, Inlapryl, in preventing glomerular filtration rate decline. And why amlodipine out of all CCBs? With over 25 years of clinical use history, amlodipine been studied over 400,000 patients and has 26 billion patient days of therapy worldwide. It can easily be said that amlodipine is one of the world's most prescribed antihypertensives. So when the two greats combine, the result is a superb combination, which provides excellent efficacy and many other clinical benefits to patients. Telmisartan+Amlodipine provides excellent 24-hour ambulatory blood pressure monitoring profile. This was evident in result of a trial, conducted on 562 patients. The combination was successful in meeting the AHA criteria for 24-hour average BP of 130 by 80 mm of mercury. Use of amlodipine as monotherapy can cause peripheral edema among patients. This is because amlodipine has selective dilation effect on arteries alone, which results in fluid accumulation in limbs. When used in combination with telmisartan, the excess accumulation of fluids is reduced, since telmisartan dilates both the arteries and veins, which balances the flow of fluid in either direction. Despite all the clinical benefits offered to patients by telmisartan+amlodipine combination, the safety and tolerability of this combination was observed to be similar to placebo and monotherapy. So, to wrap it up, telmisartan+amlodipine is a superb combination, where telmisartan compared to other ARBs has longest plasma half-life of 24 hours, highest trough-to-peak ratio of 80%, lowest renal excretion of less than 2%, highest level of distribution of 500 liters, strongest binding affinity to AT1 receptors, highest activation of PPAR-gamma, and beneficial in diabetic nephropathy. Whereas, amlodipine has clinical history of over 25 years, and happens to be one of the world's most prescribed antihypertensives. Telmisartan+Amlodipine redefines the art of control.